Good evening, everyone. Thank you so much for being here. My name is Ashley Brennan Jowett, and it's my pleasure to help organize these events for Southwestern Vermont Healthcare. Before we begin, I would like to thank the Manchester Community Library for being our excellent host tonight. They are so accommodating and wonderful to be here in this community and offer these types of presentations. Thank you to all of the staff who have contributed to this event. Next, I'd like to introduce Dr. Boggs Morris, who's going to be our moderator for tonight's presentation. Dr. Schwartz is probably known very well by many of you. He's been a family practice physician at SVMC Northshire campus for 27 years. In addition, he's the Associate Medical Director of Dartmouth-Hitchcock-Putnam Physicians. He earned his medical degree at Northwestern University Medical School in Chicago, trained during his residency at Lancaster General Hospital in Pennsylvania, and completed a fellowship at the American Academy of Family Physicians in Kansas. And he's going to introduce the rest of our presenters for tonight's talk on joint pain. Thank you.
Thank you, Ashley. We've had a little bit of technical trouble to start off, so if you came here, just let me know. It's great to see this many people here and interested in the panel discussion we're going to have tonight. Thank you all for coming. It's also great to see a lot of familiar faces here. So welcome, and we hope it's a good evening for you. I wanted to start off by introducing the panel. We have a great panel tonight. Just to my right, Dr. Michaela Schneiderbauer. She got her medical degree from Ludwig Maximilians University, Munich, Germany, and Harvard Medical School. She did her orthopedic residency at Basel University Hospital in Switzerland, and 2 fellowships, because if one fellowship is good, 2 is better, in joint replacement surgery and orthopedic oncology, and that was at Jackson Memorial Hospital in Miami. To her right, and to your left, is Matt Nofziger. He got his medical degree at Indiana University School of Medicine. He did his orthopedic residency at Fort Wayne Medical Center, and then did a sports medicine fellowship at Nerschel Orthopedic Clinic in Virginia. And then to their left, from your perspective, Yvette Gutman got her medical degree at Universidad Autónoma de Centroamérica in Costa Rica. And then Yvette did a pediatrics residency in San Juan City Hospital in Puerto Rico, and primary care sports medicine fellowship at Albany Medical Center. And at the end of the row there, Dr. Jessica O'Brien, who's a physical therapist. She got her bachelor's in exercise science from Castleton State, and then her doctorate in physical therapy from Sage Graduate School in New York. And just to let you know where these people work, let's see, Michaela works in Bennington and Manchester, Matt in Bennington and Manchester, Yvette in Bennington,
Twin Rivers and Williamstown.
Great. So Massachusetts, Williamstown, and Twin Rivers, which is the family medicine practice that's in Hoosick Falls. And Jess works at the Centers for Living and Rehabilitation in Bennington and in Northshire. So we have 2 parts to the presentation tonight. We're going to do a short slideshow that goes through some very basic information about joint pain, and then we're going to open it up for questions. And if you have a question along the way, feel free to interrupt. This is a really broad topic, so one of the things we want to be sensitive to is that you may have certain questions you want to ask that we're not really covering. Feel free to do that. All right. So first of all, what causes joint pain? Well, that list is really long, but we can classify into certain categories, one of which is inflammatory arthritis. So these might be conditions like rheumatoid arthritis or lupus, and they cause inflammation in and around the joint, and can be very serious. They can actually destroy the joint structures. They're often treated with medical treatments rather than surgeries. And some of the advertising you see on TV is medication that is for inflammatory arthritis.
The next very common finding is degenerative arthritis of joints. And we have here an example of a knee, which is one of the locations of wear and tear arthritis that is most common. And it depicts on the left what happens when you wear down your joint. You lose cartilage, but that's not the only thing. You end up building bone spurs where there shouldn't be bone, and the bone underneath the cartilage becomes really hard. The problem is that it's painful, right? You wouldn't really care if you wear down the cartilage and wouldn't feel any discomfort. And we think that the pain actually comes from the nerve fibers more in the bone underneath where the cartilage is worn down, because cartilage itself actually doesn't have nerve endings, so wearing down the cartilage in and of itself shouldn't really cause pain. So the theory is that all the changes that are going on around that joint are really causing the trouble, with the bone spurs making it stiff, and with the nerve endings being exposed causing the pain. This is a video depicting knee arthritis, what happens.
In order to understand the changes that occur in the joints of a person with osteoarthritis, it is necessary to first understand how joints work. The two main bones of the knee are the femur and the tibia. In a normal knee joint, the connecting surfaces of these two bones are covered with cartilage, a smooth and strong material that cushions the impact between the bones. The joint is also surrounded by synovial fluid, which aids in joint mobility. In people with osteoarthritis, there is a chronic degenerative loss of cartilage, resulting in bone-to-bone exposure, bone destruction, inflammation, and pain. Osteoarthritis can affect any joint in the body and is commonly found in the neck, back, and hips. The cause of osteoarthritis is unknown, but aging plays a significant role in the development of this condition.
Trauma is another obvious cause of joint issues and pain. Fractures and are fairly straightforward and self-explanatory. The injury itself is painful, then the healing process happens. During the healing process, in order to protect the fracture site, joints often get stiff, muscles around the joints get weak, and then have to be rehabilitated to get back to full functional ability. It's obviously different somewhat for every joint, and the type of fracture can be more or less stable, so the recovery can be more or less involved as far as getting people mobile again. Oftentimes when we repair or fix fractures, it does not actually make the fracture heal any faster. It simply allows us to get people more mobile while the fractures are healing. But after that, and during the healing process, then the therapy crew get involved and help minimize the longer lasting effects of the actual trauma itself.
So an overuse injury is just that. It's when the load that you exert on the tendons outweigh what the tendon can actually give you. It's usually when we take a bigger bite than we can chew in the sense of our tendons and musculoskeletal structure. It happens a lot in the pediatric age group, but can also happen a lot as we age, because our tendons take a lot of wear and tear, And we just usually think that, well, always think that we can do more than we normally can, and this is when the overuse kind of comes into play and begins to ache and hurt on us. It occurs a lot with tendons, mostly, but again, in the pediatric population, it occurs in the growth plates, where they can get injured with overuse injuries.
Many issues with joint pain actually have nothing to do with the joint. And one example of that is radiculopathy, which is where a nerve is compressed or injured. And the most common example of that is in the low back. And those nerve compressions usually cause pain that's in the leg. And sometimes a person will perceive that as being knee pain, hip pain, ankle pain. And it's hard for a person to distinguish that from problems in the actual joint.
I have a question about that. If you have that kind of pain, my doctor mentioned to me that there is a radiculo something oblation or ablation that can be done. Could anybody explain that to us?
Sure, I can explain that.
Repeat the question.
So the question was that if you have that sort of problem, there's something called an ablation. What is that? How does that work? So one of the ways to handle a problem with a pinched nerve, in particular pinched nerves that are chronic and can't be repaired through either medication or through surgery, a special procedure can be done where either medication or a mechanical destruction can actually destroy the nerve, and that can relieve the pain. It doesn't always, so it's a little bit tricky, and it's usually a multiple step procedure where the first part is to numb up that area to see if that fixes the problem, and then if it does, to do a more definitive destruction of the nerve. And those are usually either radiologists or physiatrists, specialists in physical and rehabilitative medicine, who do those procedures.
Thank you.
Okay, tendinitis. So tendinitis is an inflammation of the tendon, and inflammation produces pain. So when we become injured, whether it's an overuse injury or due to an accident, trauma, or a fall, we can get an inflammation of the tendon, and thus we'll get tendinitis. Inflammation is where the healing process begins. So remember that, because that's going to come in handy later, okay? Another slide. We could talk a little more about tendinitis. There are different ways to treat it. We can use anti-inflammatory over-the-counter medications. We can also, for those that can't take it, either contraindication or because their belly hurts, we can do some topical anti-inflammatory gels. Physical therapy is extremely helpful when it's a tendinitis. Again, that's going to come in handy a little later. Okay, itis, tendinitis. Depending where it's at, we can use certain braces. Ice is a magnificent natural anti-inflammatory agent that many of us completely forget about. We think it's only for use in the glass, and it's not. It's actually extremely useful for being an anti-inflammatory agent. We're not up yet.
Yvette, do you want to comment on bursitis?
Yep. So that's another slide a little bit later. Actually, if I may I comment on epicondylitis slide?
Yes,
it kind of ties into
please,
this, and that way they don't have to remember about the itis thing. Okay. So there's epicondylitis is inflammation of the tendon at the elbow, okay, due to overuse. And the difference between a tendinitis is, again, the inflammation is the beginning of the healing process, so it's more of an acute issue. If it becomes a chronic issue, then the tendon becomes disorganized. It loses neovascularization, so it loses all the wonderful little growth factors, and it becomes degenerative, and it loses the possibility to recruit all of the inflammatory markers, which are actually very helpful in the healing process, and thus becomes what we call a tendinopathy. These are chronic, it didn't happen overnight, and it's not going to get better overnight, but there are certain treatments that we can use to help tendinopathies. With tendinopathies, you have to keep in mind that usually it's, I don't want to say dead tissue, but it's certainly tissue that has been hibernating for a prolonged period of time, let's say, and you need to kind of wake it up and demand that it continues to work for you. And to do this, evidence-based medicine has shown that eccentric exercises have been very fruitful in recruiting some of the healing factors, because an eccentric exercise and stretches actually put a higher load on your tissue than what we would normally put on it, and thus they hurt. It hurts. It's supposed to hurt. What?
Maybe Jessica explain what an eccentric
Eccentric exercise. Okay.
I don't know.
Hi. So an eccentric exercise, I guess it's kind of easier to explain what a concentric exercise is first. So a concentric exercise is, say, I'm working this muscle here, I'm pulling up. That's a concentric exercise. To do an eccentric exercise, it's slowing the motion on the way down. It's doing the opposite of the concentric exercise.
Yeah. So you're shortening the muscle with concentric exercise. You're lengthening the muscle with eccentric exercise. Okay. So an eccentric has been fruitful for tendinopathies, not so much with tendinitis. So I guess at the end of the day, it's imperative to get a good diagnosis so that you can help the therapist help you. So we're just going to wait to explain things.
Where does the cortisone shot come in?
Remember, you're asking a non-operative sports medicine physician when the cortisone injection comes in. So I am conservative. I'm a conservative physician. I like to do things in a stepwise function. Cortisone can be helpful to reduce inflammation and thus pain for a short period of time. Sometimes that effect is enough for it to go away and never come back. My experience has been it's only temporary. Then you rip out the Band-Aid, you've done nothing this whole time because, hey, the pain's gone. So you've done nothing to really cure the issue. And when the steroid wears away, here comes the pain again. So I don't like to give you that quick, easy fix, because then you won't put in the hard work of physical therapy and of home exercises. Yes, ma'am.
A friend, within the past few months, went to a doctor with knee pain. She needed to make a drive from Pennsylvania to Florida, so she went to the physician to help her get able to go, and they gave her a cortisone injection. She was later diagnosed with 2 spots going on bone in that knee, and they refused to do the surgery because she had had a cortisone injection because of an infection. How does cortisone cause an infection?
The reason the cortisone helps you with the pain, injection helps, is because what we call an immunomodulatory drug. So the same cells that you need when, let's say, you have pneumonia, the white blood cells that need to clean up the pneumonia, they're also involved in the knee pain. They are the ones that kind of make the pain fibers fire, in a way. They spit out all these molecules that make the pain fibers fire more and give you more pain. So they are good when they need to clear up the infection. They are not so helpful with pain with arthritis. They actually promote the pain. So what the steroid or cortisone injection does, it makes those white blood cells lazy and numbs them down and not work so hard. But that also means your immune response or your immune system in that knee, let's say you got the injection in the knee at that moment, isn't that strong because they kind of were incapacitated, if you will, the white blood cells that are also important for fighting an infection. So I'm, mainly doing hip and knee replacement surgeries. That's my specialty, and we have a lot of data with science where people have looked at patients that had a recent cortisone injection in a joint and then a surgery. And the time between those two things, injection versus surgery, at and it's been shown that if there's less than 3 months in between, the infection risk goes up. And it's actually still persists at 4, 5, 6, 7 months also, but not so dramatic. Okay? So the more distance, as a surgeon, the one thing that I absolutely do not want is for my patients to be worse off after surgery than before surgery. A scenario where they will be worse off than before surgery is if they get an infected knee replacement or infected hip replacement. So I want to avoid that at all cost. And one of those is asking, did you get a recent steroid injection? If somebody tells me I got one last week, I'm like, can't do anything for you for 3 months.
Sounds like they need to do the MRI before they get the injection.
MRI is really not crucial.
Well, whatever it is that was diagnosed that she needed a replacement.
The X-ray. For like wear and tear arthritis, I hear like a lot of people come and ask me for, hey, do you need an MRI? Typically, if you don't, I guess is the simple answer. For something that is bone-on-bone arthritis or significant wear, you can easily see that on a simple X-ray that can be done in the office right then, right there. MRIs are helpful when you're asking, do I have a pinched nerve in the back, or do I have a rotator cuff tear or something like that. But for bone-on-bone arthritis, a simple X-ray is enough. If I was the patient, I would start with an X-ray first, and then if you already see it there, you can spare the MRI.
Just to give a family medicine perspective on that, one of the things we do is try to help people not need surgery. So one of the ways to do that is by doing a steroid injection, particularly in a situation where someone has a special event. That's a reasonable thing to do. Even if they have severe arthritis that may ultimately need a joint replacement, that still may be the right choice for that person at that time.
I think it was essentially what the scenario that you described was sort of a communication breakdown, right? Probably the person came to a doctor and said, I'm needing to do this long drive, help me out, like I need the help now. And the communication didn't go further to saying, but then once I come back from Florida, I want to do the joint right away or something like that, If that was in the plan, then I think...
The cortisone didn't help. She ended up wanting or needing knee replacement and couldn't have it.
And it's always a struggle because, I always say you want to try whatever you can to delay or avoid a major surgery. And sometimes you see terrible looking arthritic bone-on-bone knees that don't hurt. Usually when we get an x-ray of a right knee, the one view shows both knees on it, and it's not unusual that you'll see, the other one looks as bad or worse, and it doesn't hurt, and you don't really want to, you don't not tell them, but you also don't want to plant that seed too much. So, and cortisone shots, every shot I say, this may help a lot or it may not do anything for it. But if you would be wanting to move forward with surgery sooner than later, this is the reason not to do that. And you see everything. Miracle cures with cortisone and didn't help me.
Jess, do you want to comment a little bit on ways to prevent arthritis and joint pain?
Sure. So where my job kind of comes in is preventing joint pain. You want to stay healthy weight, healthy diet, exercise, all that sort of stuff to kind of maintain your joints. Trying not to get injured is a big thing. And maintaining good mental health. I think Dr. Schwartz, you wanted to touch on that a little bit?
Yeah, so I think mental health issues are really important when we're talking about painful conditions. And I'm sure many of us have been in severe pain, and there aren't many things that make you more anxious. If you have that for a long period of time, that can make you depressed. But the opposite thing can happen as well. Those pain impulses, when they get to our spinal cord and our brain, are changed and modified. And if you're depressed or anxious, your pain is actually worse. And so it's really important when you're dealing in particular with chronic painful conditions to make sure that the mental health issues are addressed, either through medication or therapy.
May I interject real quick?
Yes.
Okay, I told you I was long-winded, I tried to warn you. But looking back now that we're up again, we did skip one slide, and it happened to be mine, it was about bursitis. So I just wanted to quickly speak about bursitis, if I may. Wonderful, because I think this is where a steroid injection really can be helpful. So what is bursitis? So bursitis is, I like to describe it as an empty water balloon. And it's between the bony prominences and the tendons, and when there's a lot of friction between the tendons and the bony prominences, the water balloon's job is to kind of fill up with water and protect your, tendon, bony area from continuous friction and injury. And this produces pain. And so sometimes a steroid injection into these bursa, some of you may know either a greater trochanteric bursa is a common one, the subacromial bursa in the shoulder is another common one. This is where I think there's some good results with steroid injections for alleviation of pain to endure the physical therapy to get through it, okay?
Gentlemen.
Has there been any clinical studies, or is there any way that you folks would have of knowing about whether turmeric in capsules will do something to alleviate pain? And if it does, is that only for tendinitis as an anti-inflammatory, or what's going on there?
So his question is about turmeric. If turmeric in capsules have been proven to have any anti-inflammatory effects. As far as I know, evidence there has been some studies out there that show that it is as effective as diclofenac, for example. They've converted it into capsules because, they're smarter than I am. But before we just used to say, put the turmeric spice in your food. It is a natural anti-inflammatory product or supplement. As long as you're not allergic to it, I don't think there's really any harm in trying it. Diclofenac, it's a
Voltaren.
or Voltaren.
A prescription anti-inflammatory.
Yeah, prescription anti-inflammatory.
And I would add any of the supplements, glucosamine, chondroitin are very common, turmeric. There are many things out there, and I am quick to say, whether it's a pill I prescribe or something you can get at a natural food store or wherever, if it helps, and there's no harm to it. If it doesn't help, it's not really helping. There's not good data say glucosamine. People that sell it will say, it will prevent arthritis or rebuild cartilage. There's no evidence for that. At the same time, there are some studies that say up to 40% of people that take it feel better. And if that's all it takes to keep you away from even routine ibuprofen, the harm of glucosamine is nothing. But the harm of ibuprofen, the harm of diclofenac, the harm of cortisone shots, the harm of surgery, they all carry harm to the potential harm. So if something like that helps, good. If it doesn't, I'm cheap and I don't like to take pills, so I wouldn't keep taking it. But again, that stands for what I have to sell as well. If it doesn't help, there's no benefit to diclofenac or any of the prescription anti-inflammatories.
That sort of answers my question. I got to say, ibuprofen up there. Advil is like a miracle for me. And, but a couple of doctors have said, you got to be careful taking Advil. Can't take too much Advil. I take 2 pills every other day.
So most of the things you can do have some benefit and some risk. Okay, so the question was, is ibuprofen a miracle drug? Is that a good summary? And for many people it is.
My real question is there a real danger? Because it really works for me.
Yes, there's definitely a danger. So medicines like ibuprofen, which is Advil, Aleve is naproxen, that's in the same class. They do have hazards. They can have negative effects on your kidneys. They can cause stomach ulceration and gastrointestinal bleeding. They make the platelets in your bloodstream, the little fragments of cell that clump together to form a clot, not aggregate quite as well, so it makes it harder to clot, and that's not that big a deal until you hit your head and are worried about a brain bleed. And then finally, they have been associated with some increased risk of having a heart attack because of the effects they have on the platelets. So most people are able to tolerate them well and do fine without side effects, but as with most things, there's a positive and negative side to it. So I think your benefit is enormous, and so a small amount of risk is worth that. If you are taking these medicines and maybe not getting that much benefit, you might be better off not taking them and avoiding the risk.
And I would also say, don't use it just as a preventative every day. You're better off taking it when you really need it, and be aware that that's how you can actually mitigate that risk to some degree. But people that come to me and say, I take, ibuprofen 5 times a day, every day, I get concerned, right? And there's plenty of people like that out there.
Yes.
Acetaminophen has the same effect.
Yeah, so the question was, does acetaminophen have the same effect? So that's Tylenol. And it does not. So it is, on average, somewhat less effective for controlling pain in general. And it does not have the same negative effects on the stomach. Probably not as much negative effect on the kidneys, although some. And the main problem with acetaminophen is that if you take even a little bit too much, it can cause a very serious liver problem. Or if you're someone who has liver disease or is a drinker, alcohol drinker, even normal amounts of Tylenol can cause liver damage, really to the point where you have liver failure. So we all, know our neighbors all tell us, oh, if one ibuprofen works better, you can take 3. Well, that's true, and actually, we prescribe often up to 4 of the over-the-counter ibuprofen to get to the maximum dose. But if you do a similar sort of thing with acetaminophen, you can really get in trouble fast. So it doesn't work quite as well. If it's taken properly, probably safer. If you veer at all from that, probably more hazardous.
One more thing on that. I personally like to use the over-the-counter anti-inflammatories as first, second line options. Don't know how to make that stop. The general recommendation is take as little as you can for as short a time as possible. And people may have a thought that a prescription something is better than over-the-counter. The ibuprofen is the same medicine as Motrin, and anything more than 1 pill 3 times a day is a prescription dose of ibuprofen. And I like ibuprofen because if you give a script for 800 milligrams 3 times a day, if that works, great. But if 600 or 400 or 200 works, you can change that dose yourself. And the same with Aleve or naproxen. If we write a prescription, it's typically 500 milligrams twice a day. Over-the-counter Aleve or naproxen is 220 milligrams. So take 2 of those twice a day and you're getting a prescription dose of naproxen. But I don't need it, don't take it. Or I need a little, take 1. And so you can choose to take less, whereas if you have a prescription and it's just 1 big pill, you can cut it, but most probably don't bother.
There was another question.
Yeah, I was wondering with the glucosamine and the chondroitin and the turmeric, all that, if you think you want to take that, shouldn't you be checking with your doctor first to see if there's any interactions with your prescriptions?
So that's,
I mean, you can't
I
just
think,
go out and buy it and take it if you're taking a whole bunch of prescriptions, right?
I think that's always a good idea. And
Are there any known interactions with?
well, so part of the problem with these preparations is that they're not regulated. So there's wide variation in what's actually in the preparations. And in terms of herbal remedies, which we're not talking about here, but it's somewhat equivalent, there have been studies that have shown that sometimes there's no active ingredient in the preparation. So I would say, good idea to consult your regular provider to make sure that everybody's aware of what you're doing, and then they can also make recommendations about what you might do in addition. So, if you, for instance, look at this slide up here about what you can do to relieve joint pain, I think of some of these as being what your grandmother would have told you to do, right? Ice it, take a Tylenol, rest, so those aren't rocket science. There are topicals out there that can be used. Probably the most commonly used topical available over the counter is capsaicin, which is hot pepper juice, and that seems to be effective. There's also a topical lidocaine patch available over the counter, and those can be beneficial. All of these things can be combined. So, you might combine turmeric, ice, some ibuprofen on occasion, and other sorts of modalities. So that's another reason why you might want to be in contact with your provider to really come up with a comprehensive plan for your joint pain.
Bob, correct me if I'm wrong, but I think mainly the interactions that you need to be worried about with supplements is when you're on any kind of blood thinners. There's quite a few supplements that might actually either counteract that action or make it more potent, and that's an uncontrolled thing then, right, and could really put you at risk. So if you're on some sort of blood thinner for the heart or similar conditions, you should definitely share if you take supplements.
Okay, so this is where physical therapy comes in. It is a great step in the multidisciplinary approach for treating the signs and symptoms of joint pain. Physical therapy, we use a lot of different treatment methods: strengthening, stretching, education, manual therapy, and sometimes modalities such as therapeutic ultrasound or electrical stimulation to help you modulate your symptoms. The goals of physical therapy or manipulative treatments are really your goals. We're trying to help you return to your normal activities if we can. Hopefully, if physical therapy is successful, we develop a good flexibility and strengthening program that you can continue to use even after you're graduated from physical therapy. If you've ever been to physical therapy, you better still be doing your exercises. So that you can help prevent symptoms, and if you do start to get symptoms, you know how to manage them yourself. Unfortunately, sometimes physical therapy isn't the best option, and if that happens, if we feel like we're not happy with your results of physical therapy, I'll refer you back to either your primary or your orthopedist to look at further options for care, which we're going to talk about next.
So, steroids, joint injections, okay? Again, not my knee-jerk first reaction or treatment for you all, but if you would like to try that, specifically because of osteoarthritic pain that is just unresolved with the previous conservative treatments, I do ultrasound-guided intra-articular injections. There are a couple of spots that you really can only inject accurately with ultrasound guidance, specifically the hip and the shoulder joint, as well as there are some tendons that we can make sure that we get to. The knee, I can also do it with the knee, but usually you can do that with blind landmarks. But sometimes if there's a really big aspiration or, we want to put in Synvisc, which is hyaluronic acid, that I think we'll speak about a little bit later. You may want to do it using ultrasound guidance. They've done a study that showed that with this product in particular, if you do it blindly, if it's not in the right spot, usually it's about a 30% that it may not work. So if it hasn't worked for you in the past, then, we can maybe, do it with ultrasound guidance. You don't miss with that. It's like having the lights on versus using good, experienced, landmark injections. For the knees, really, you don't really need it, okay? But for the hip and shoulder and other tendinous injections, it's extremely useful.
So we have a question down in front here, Leo.
Yeah, what is used for the joint injections?
So I use Kenalog. I use Kenalog and lidocaine. It's a corticosteroid. I use 40 milligrams of Kenalog, and I use 3 milliliters of 1% lidocaine.
But are you asking different options? Are you asking?
Because there's different style or types of injections that you could perform. You probably heard about the steroids, not plenty, but there is sort of a lubricant substance that is the hyaluronic acids that can be tried. When you ask the American Academy of Orthopedic Surgery, they say there is really no good evidence that the lubricant substance is any better than the steroids in terms of the pain relief. And they're a lot more expensive. Some insurances don't cover them. Then there's injections like stem cells, which is a big hype, or platelet-rich plasma, which is harvesting your own blood and then spinning it down. And the platelets that Dr. Schwartz doesn't want to aggregate when he gives aspirin, those you re-inject into the joint. So I guess you have to ask ask yourself which injection you would want to try. With some of them, there's a significant cost involved, but Yvette will talk.
Yeah, so I'll talk about platelet-rich plasma because we will actually be offering this in the next couple of weeks. We will start I will start doing PRP injections into the joints. So PRP is platelet-rich plasma. What does that mean? So platelets are, I'm sorry, sir, do you have a question?
Do those injections work on knuckle joints on your hands?
Ooh, I have not, the PRP injections? The PRP injections, if they work on the knuckle joints in the hands, I have not seen any data on such small joints. I haven't. So PRP is platelet-rich plasma. So we draw your blood, so the side effects are minimal. We spin it down in a specialized centrifuge, and then we concentrate all of the platelet-rich plasma in a certain syringe, and the platelets have a lot of growth factors. So we ask before this injection that you actually stop the anti-inflammatory agents, because what we're trying to do is recruit the anti-inflammatory or the inflammatory agents, because inflammation is the beginning of the healing process, okay? And PRP does this by putting a small dose of concentrated platelets, which has the growth factors, which recruits all the little helper cells to begin the process of healing in an osteoarthritic knee or a hip or into tendons. Okay? There is no guarantee that this will work. There is a lot of studies, more so than stem cell, that do show promising results. For example, if I may, they have done studies with hyaluronic acid injections, which are your Synviscs injections, versus the PRP. And at 6 months, they show the same result for both. Same result for pain and same result for function. However, at 12 months, the PRP has seen a significant amount more of pain relief and function. The issue is that insurance does not pay for it yet. Okay, so it is a cash pay procedure. So if you're looking at a long-term investment, you may want to consider PRP. However, insurances usually cover hyaluronic acid every 6 months, so if you can't afford PRP, it's not like that's your only option. We can also try the hyaluronic acid injections to help with your osteoarthritic pain.
This might be a little bit related to that. I'm not sure I had the right terminology to this. What some of us non-professionals might have referred to as a roto-rooter osteo, whatever they go into the knee, does that mainly remove bone spurs? Does it have any beneficial effect on the cartilage? Is there anything that might benefit cartilage regeneration?
The question is, essentially, is arthroscopic surgery, helpful surgery to go in and clean up the knee, is there any benefit for arthritis? The short answer is not really. The short answer is not really. Why? I qualify it a little bit. There's quite a bit of data that says it does not help for pure arthritis. For a healthy joint so we confuse people by talking about cartilage. The surface cartilage is the slippery smooth stuff that coats the end of the bone. The meniscus cartilage is the cushion cartilage that if someone had a torn cartilage, it was a torn meniscus. So the younger knee with a torn meniscus has a mechanical problem, and that's where arthroscopic surgery really is.
It's probably too small, but
is most helpful. Arthroscopic surgery is done at times in an effort to try and delay surgery. I'm 48 years old. If I had an arthritic knee, I would maybe try to have an arthroscopic surgery to gain some time, but it's not reliable at all. So, correct.
What about cartilage regeneration? Anything we can do for that?
Ken, the short answer is no. I will stay on a soapbox for a second. There's a big marketing push out there in regenerative medicine for stem cell injections. I would put it in the category of something that doesn't have any real solid evidence for it. Clinic A versus B versus C versus D stem cell is not the same across the board. So any study looking at stem cells really has a lot of variables that are not well controlled. And where they get the stem cells, what are they actually injecting, even if they get them from yourself, there is potential infection. There have been plenty of reports about those kind of things. And they're very expensive. I have heard from patients from $5,000 to $12,000 per injection for something that doesn't have good evidence for it. Was that?
Mine did not go. I had possibly at first, and I went into a program. I had knee injections that actually regenerated certain components.
Yeah, but what I've seen, two of us worked down in Miami for quite some time, and it was a lot of places offered stem cell injections. They looked, first of all, there's a terminology thing, because a lot of centers that do this cash business, they label platelet-rich plasma, PRP, as stem cells. So when it's not as pricey, if it's not at the 3,000 up price range, you did not get stem cells. Pretty sure.
It wasn't.
Yeah, it was probably PRP.
This was a medical program that I had gone into.
Yeah.
I was very successful.
Yeah. No, I mean, who cures, who heals and cures is the winner, right? Like, so I don't speak against that, and I'm glad it helped. But we try to read pretty much like evidence, right, and listen to our official bodies, like what our American Academy of Orthopedic Surgery says based on what we consider the highest level of evidence, which is a randomized controlled trial, meaning you and a person just like you with the same age, same diseases, same whichever joint it was at the same stage of disease. One gets a needle put in with stem cells and one gets a needle put in with nothing. And they don't even know that they didn't get anything. And then look at the outcome. And if then you do way better than the other person, then we know stem cells have worked better. No such study exists. And so that's the problem, right? And there's actually, recently I've seen a publication in our best journal that questioned the ethics of the stem cell marketing. Because it said there is actually two sides how you could look at that ethically, right? If the people who do these injections are convinced that they're really so potent and so excellent, that should be accessible to all patients, right? Not just to the ones who can pay. So if the evidence-based, if like randomized controlled trials, the highest level of a trial was there, insurances would be forced to pay for it, right? There's no way around it, but that doesn't get produced. And so, do you understand what I'm saying? Yeah?
So we have another question here on the right.
I live in Tampa, Florida, and we have these clinics popping up all over the place. Free seminars, come for lunch, that kind of thing. But my question is, if we shouldn't take a leave, or naproxen or meloxicam or whatever, if we shouldn't get the steroid injection because it probably isn't going to help other than the short term, if we need to be very leery of the marketing of all this PCP and stem cell and all that kind of stuff, why in the world are we delaying having the joint replaced if that's going to fix the problem?
So I'll start with this, but I would just say, argue with your premise a little bit, because all the things you mentioned may be reasonable treatments for any given person. So things like the anti-inflammatories in people who are otherwise healthy might be a great choice. There's also, from the perspective of primary care, you know, we try to postpone this sometimes because the technology really advances. And, you know, getting a joint replacement 10 years ago is not the same as getting it today. And maybe you can speak a little bit to that, Michaela.
But maybe first to get back at your comment, which I think is you know, an excellent comment that probably a lot of the people are thinking in this room that heard the discussion so far. But in a way, there is no free lunch, right? I think a lot of people, they have a bad knee. Let's say worst case scenario, they've been overweight for decades, they have had a skiing injury, and then it's because it's a bit nasty too with arthritis sometimes, because it creeps up on you. You don't really feel it that bad for many, many years, but it's happening. You just don't know it. And then one day it hits you hard and you're in a lot of pain. And it's sometimes related to lifestyle choices that have been made for many decades, and you can't really reverse that. But I think it's legitimate to think about, in early stages of pain at least, can I maybe reduce my weight, get more physically active, walk? Arthritis is actually not an excuse to not be active anymore. To the contrary, we've seen that low impact exercise, which is walking, bicycling, swimming, helps with arthritic pain. So that is an intervention. Weight loss is an intervention. So that's outside of medicine, right? Then I think there is no harm in taking the occasional Aleve, the occasional Tylenol if it's not on a daily basis when you have a rough day, and otherwise you're good for a week and you just need it. So at that point you're not in a way bad enough to really want to go through a surgery? Probably not, if one Aleve every 2 weeks fixes the problem. So it is sort of a stepwise approach. Then there's also justification, I think, totally for the injections, because there's plenty of patients that we cannot, with good conscience, recommend surgery for. If they have a very bad heart, very bad lungs, and we have huge concerns with surgery and anesthesia, and they might not survive it, what else can we do, right? In that case, I will, as a surgeon, say, you know, we want to not do you harm, right? And there is plenty of patients out there. But then if you get to the point where you're like, yeah, I mean, I want to play golf again, I want to, you know, do my doubles tennis or something like that, and that is my joy in life and I can't do it because of the knee. Sure enough, the knee replacement is an option then. And a good option. More than 90% of the people are very, you know, have a very good outcome with that. And if, you know, like Dr. Schwartz said, if you had a knee replacement 10 or 15 years ago, it's not what it is today. More and more centers are doing it outpatient when the patient is really fit and has a social network that supports them. Most of our patients here at SVHC, they really also only stay a night for a hip or a knee replacement, and they're comfortable going home. Because our pain management has improved, our surgical techniques have improved, the implants have improved. People come to me and say, I was told I should wait, and I'm really miserable because they only last 10 years. Nowadays, implants, they last 20, 30 years. So if you're 70 years old, I say to people, and they're concerned, I'm like, how old do you want to get? Right? Like, if I tell you it lasts 30 years, you tell me you're 70, is that going to be enough for you? So kind of like, and then even if you get to 100, 105, you're most likely not in a state where even if your knee replacement has failed or is loose, you necessarily want to have a revision surgery, right? It's more of a concern when you're in your 30s, 40s, when you had like Dr. Nofziger, he said, you know, trauma in your earlier years of life, let's say sports trauma with bad meniscus tear and ACL tear when you were 20 years old, that's the starting point for a bad knee arthritis in your 40s or 50s. And that's where we have a bit more concerns, because when I tell you in your 40s you have bad knee arthritis, I tell you really the only thing that's left, because we've tried this and this and this and this, and you're still miserable, is knee replacement. Somebody that is 40, I have concerns. Because also they use it differently, right? When you're 40 years old, you want to run your 6-mile running race. You want to, do different things than somebody that's 65 or 70, and they might wear it out quicker. And they're not as happy with the artificial implant either, because it is artificial. At the end of the day, it's a good pain management tool, a process to go through, but you will always be able, with the most modern implants, especially with knee replacements, you still will be able to tell it's something artificial, not something natural. There's something we call the forgotten joint index, meaning which type of joint replacements have a higher rate of people just entirely forgetting that they ever had the surgery after a while. With hips, that happens a lot, with hip replacements. With knees, not so much.
Do you have a question in the back?
Yes, I've had multiple knee replacements, knee replacement failure, and then I've had revision surgeries. And what I'd like to know is how many times can a person go through and have a knee revision? How many times is that feasible to have a knee revision, and is that a good risk?
So,
I've had one revision on both of them.
So, what's your... Kathy. So Kathy is asking, how often can you do a redo on a joint replacement? She's already had the original surgery and then 1 or 2 revisions on each side. And she's asking how often you can redo these. That's not a simple answer, because it depends on what your bone looks like with the implants. Because every time you have to do a redo on a joint replacement, it doesn't really matter which joint it is. But at the situation where you have to do a redo, you need to anchor the joint much deeper into the bone. Because this is a model of a knee replacement. If I could just, I don't know if you can see it, but the plastic that is see-through is representing the bone. And the shiny metal pieces are parts of the surface. Actually, it's really a new surface that's capping the end of the thigh bone here and the end of the shin bone here. And when we do the original knee replacement, we really only cut off a very thin sliver of your own bone. And we just recap your own bone with now a smooth surface again instead of the bumpy bone spur surface, and make it a smooth movement. When this gets loose, like these implants are starting to kind of fall off the bone, they rattle off some bone behind it, meaning you're losing actual bone with the loosening process. So now when we have to redo that, we have to typically anchor the new revision replacement much deeper into bone, with like stems up into the thigh bone high and stems into the shin bone deep. And to redo it once is usually not an issue, but it's a much bigger surgery than the original. That's why we try to have patients do their replacements only once in their life. And if we can, talk them into waiting at least to their 50s, not do it in their 40s. But after the first redo, now you're really having even less bone. Now you're already anchored with an inside the bone stem up the thigh bone and up the shin bone. What else are you going to do? Now you need a longer stem, a bigger stem, and you're replacing more and more of your own bone with artificial metal. And at some point, there isn't enough bone left to really anchor the next revision and the next revision. So one redo is usually fine. The second one becomes a real headache.
What happens when that kind of device is as is happening in New York State?
Okay, so the question is what happens when one of these devices, if you have any kind of artificial, really it's true not even for orthopedics, it's for any kind of device you have in your body. What happens if you have that in your body and then you get told, oops, recalled, it's in the middle of your body. I could talk an hour about this problem, but it's the gist of it is you want to be wise. Because some implants, even if they have officially been recalled, go back to the physician who put it in, get in orthopedics x-rays, look at it. Do you actually have symptoms, right? If it's recalled but you're doing just fine and the x-ray looks okay, it's not like it's exploding on you, I would not go into a second, like redo surgery just because, right? If you have symptoms, and let's say it's like triple the size, yeah, you're kind of bound, right? There's some that are... Yeah, but usually with the legal case you get paid either way if you redo it or not redo it, you know? But it really comes down to how devices are regulated in the United States versus pharmaceutical. Your pills you take are tested much more than any kind of device you get put in. It has to do with the laws of the land. And it's, in my opinion, not to the advantage of the patient. So if in any kind of device in medicine that's implanted in you, somebody tries to say this is the latest and greatest, I'd be careful. Because the latest and greatest makes you the guinea pig with devices. So how I approach it is I want to see an implant on the market for at least 2 to 3 years to kind of see through the first wave of potential recall if it doesn't work out, so that I'm not having to call my patients and say, oopsie. You know, not a good one.
I'm sorry, I would just like to say that PRP and stem cells are not the same thing. They're not the same thing. I agree, there's not enough literature and evidence for stem cells. I've done stem cells, I know how to do stem cells. I'm not going to offer the good people of Vermont stem cells unless they twist my arm. Because there's not good evidence-based medicine for it, and it is extremely expensive. PRP's been out a lot longer than stem cells, and we do have some evidence that it does work, so I just wanted to put in my 2 cents about that.
And my answer on the total knee is, to me, it's the last option you should consider. There are some people that say, well, if you do it earlier, before you're very stiff, you might have a little better motion, and that's not untrue. But if you're not miserable, we're sawing off the ends of your bones, and we're using a hammer to pound new things in there. It hurts. It's a big deal to go through. And the problems, revisions are worse than the first time around. They don't work as well as the first time around. An infection is a life-wrecking problem. So it's something, it's a serious thing to take into consideration.
If you inject with collagen, you have some period of time where it's effective, right?
So I think what you're referring to is the hyaluronic acid. I'm sorry. You're saying, I think your question is, you said collagen, if we inject collagen into the knee, but you referred to the rooster's comb. And that is hyaluronic acid, actually. And it did originally come from a rooster's comb when we gave a series of 5 injections. We used to inject the knee weekly 5 times. And then they got, new and better things. And then it was a series of 3 injections. And now, hey, it's a series of 1. So I haven't heard of collagen being injected into the knee. It's just 1 shot now.
Yeah. But how long does it last?
So that's the study that I mentioned previously when I compared it to PRP. It depends. Hyaluronic acid is a high molecular molecule, and when we have osteoarthritis, we have some hyaluronic proteins in our synovial fluid, and the osteoarthritis breaks that down to become more of a low molecular molecule in our knee. And so we inject the hyaluronic acid in hopes of, yes, lubricating, being a filler, and hopefully, yes, providing some alleviation of your osteoarthritic pain. They think that depending on the amount of, it's an enzyme that I can't pronounce for you, but depending on the amount of that enzyme that you produce in your body and how much osteoarthritis you have, that really depends on how long it's going to last. It's extremely patient independent. Yours may last for a year, and someone else's may only last for a couple of months, and somebody else may say, that didn't work for me at all. So it's really a hard question to answer.
And I think it's fair or appropriate to mention now, things have changed seemingly in the last 6 months, where different insurance companies are denying it more and more. Blue Cross from Massachusetts has not paid for this type of injection for quite a while. I could be wrong, but I think it's Blue Cross Vermont has recently started requiring pre-authorization, and they're giving no and no. So but again, to me, it's an option that's out there that has very low risk. I flat out tell people again, it may help you a bunch. I have people that go for years with terrible looking knees with that, and I have people that it didn't help at all.
Right in the back.
How do people do that have rather severe osteoporosis with joint replacement?
Actually, osteoporosis is bad for you and you should really tackle it, but for the joint replacement, it actually doesn't really impact the surgery all that much. We have techniques to overcome that problem, so it's really not that much of a concern. But it should be a concern overall, right? Like fracture risk, etc.
I just wondered about if you could do them all.
If you can do them all, you can do it with osteoporosis, no problem.
What can you tell us about CBD and pain?
I would say I want to be in the business. I'm honestly not that educated on it, but I think if I have a lot of patients who tell me, I used to take narcotics and now I'm taking CBD instead and it helps me, I'd say, well, go for it, right? Like if the narcotics are definitely more harm to you than CBD.
Topically or orally or what?
Patients report both to me, but do you know?
So I can tell you that all CBD products are not created equally. There is actually a difference in the concentration. There is also a difference in the way that you absorb it, whether it's topically or those little sublingual drops. I can tell you that many patients, I prescribe the prescription strength anti-inflammatory topical, and they're like, that doesn't work, but CBD oil does. And I'm like, great, keep using it. So again, it's a matter of which one you choose and how it affects you compared to someone else.
So I think we alluded to this a little bit, that it seems to be pretty safe, and I'm only aware of one circumstance with a bad batch where people seem to have problems with it. Excuse me. So that makes it something that's a little easier to use when you have very little risk in using it. It also seems like there's probably a pretty large placebo effect, which is fine, right? And who cares why the effect is occurring if it's your joint? It seems like there's a lot of hype, and it's going to be really hard to believe that it's going to really cure everything.
I kind of always jokingly say, if I could figure out how to activate the placebo effect easily, I would love it, right? I totally agree, it's not a bad thing.
So the question is, what are the recommendations on braces, sleeves, compression sleeves on various joints?
Typically, My recommendation as a physical therapist is I try to strengthen that area first. I kind of use braces and that sort of stuff as kind of a last resort, because once you start bracing something, the muscles don't have to work as hard and you get even more atrophy. Sometimes it is appropriate. If the pain gets to be so severe that the only thing that will help is bracing, then yes, we do look at bracing for sure.
I'm gonna argue with you. For arthritis in particular, there are certain braces called unloader braces that can torque on your knee a little bit to take, if you have worn out one half of the knee, those can be very helpful. They're obnoxious, they're big, they're bulky. I make patients go home and look them up before they agree to get them, because they're about $1,000, and insurance may cover it all, or they may cover, the worst I've ever heard was 50%, but a $500 trial of a brace that you knew before you got it that you weren't going to wear it is not worthwhile. Knee sleeves in general, after an ACL, are shown to be as good as the $1,000 custom ACL braces. Neither of them prevent your ACL from seeing stress. And a $20 knee sleeve is, to me, a no harm, no problem. If they make you a little more comfortable, I would argue you're more active and you're more using your muscles than if you're not. And if they keep ibuprofen out of it, if they keep you away from a cortisone shot, the harm of the sleeve, unless it gives you a rash, I would say it's zero harm.
And $15.
You can spend probably $10, $15, or you can spend, Bauer Fine braces are $180, and they're Coke and Pepsi, so they're really not that different.
I'm going to walk the line, and I'm going to say that there is a place for braces. They do make some wonderful osteoarthritic braces. I don't know if you've seen the one from Breg that actually only has the brace on the one side. It's an offloader. It's amazing. I saw it yesterday. So there is a place for braces. However, with acute injuries, you brace to help alleviate pain, to provide confidence and support and a little bit of stability, but that's it. Acute phase only, because then the brace crutches you, and it gives you it weakens your muscles, and it does exactly what you're supposed to be doing. You're supposed to be building muscles, and I'm bracing you, and you're doing the exact opposite. So I think there's definitely a place for compression and braces and everything else, and they're both great.
We're going to have to argue about this later.
Okay, another question in the back, please.
Can you tell us a little bit more about the joint replacements themselves? Do you order them off the shelf? They come in various sizes, or are they custom made?
The question was, can you tell us more about the joint replacements in particular? What do the prosthetics look like? Do they come in different sizes?
All of the,
or colors?
Yeah, all of what you mentioned is true, right? There's off-the-shelf ones, there's patient-specific custom-made ones. There's also an in-between kind of version where the jigs to make the cuts are based on your anatomy. And then it's still an off-the-shelf implant, if that makes sense. So there's these different versions. It sounds enticing to say, hey, it's matched exactly to my anatomy, right? And I've used the patient-matched, they were called, patient-matched ones for a while, and when I looked at the results, I'm like, not really that much different, right, than the custom shelf one. But the custom shelf ones are not what they used to be anymore either. That sounds kind of like cheap, but it's really not, because there used to be, at the early phase of knee replacements, for example, like 3 sizes. 3 sizes fit all. All of the companies now have like a variation of, because you have 3 parts to the knee replacement, right? And they have at least 8 different sizes on each one of those parts. So you can 8 by 8 by 8, there's like a huge amount of combinations you can have that can definitely match your size. So we measure during the surgery the size of your bone and then match it exactly like this one looks, and it's a perfect cap of your bone. Why I think evidence-based medicine, again, hasn't really shown an advantage with the custom-made implants is because you would have to know what your custom-made perfect knee looked like when you were 20 years old. Not now that you're arthritic and have worn down and have changes and have bone spurs and have, not the same alignment anymore. So now, and don't have your 20-year-old knee available, right? So now I'm doing a CT on an MRI on however old you are, not 20. And that's an altered version of your optimum. It's not your optimum that you had when you were 20. And is that really the ideal base to base the implant, the custom-made implant from? And they all work on assumptions. Ultimately, most of them aren't really custom-made, they just make smaller steps of iterations. It's a bit of a marketing thing, right? A lot of it is marketing too.
Absolutely marketing.
There was some.
I'm wondering, what are the likely causes of knee pain after knee replacement surgery? And I don't mean a week or a month, I'm talking, a couple of years later. I spoke with my brother who's had 2 knee replacements, and he described the same scenario as I have. Right, I have osteoarthritis, I have trouble getting up and down the stairs, I have knee pain, so does he. But he's had 2 knee replacements, so what are the likely causes of his pain?
I would have to do an exam and have to see an X-ray. Oh, repeat the question. So, if I understand your question correctly, you said, you have knee pain, you don't have replacements, your brother has 2 knee replacements and has the same knee pain that you have.
That's
and
right.
You're like, what are the causes why does he have 2 knee replacements and still have the same knee pain that you have?
Right.
So, I would have to examine him, I would have to see an X-ray, and also I would love to see an X-ray before the surgery was done. Because there's a multitude of reasons. If you look at the orthopedic science literature, about 10 to 15% of knee replacement patients are not entirely happy with their result. If you look in the geriatric literature, which is internal medicine for older people, they say 30% of patients with knee replacements are not entirely happy with their result. Who do you believe? But it's, there is, especially with knee replacements, a good amount of patients that don't have a home run. It can have a multitude of reasons. Number one, maybe the knee replacement was never done for the right reasons, and it was something that we call referred pain, or a pain that wasn't really related to the knee arthritis, even though the person maybe had some changes on the X-ray, but the actual pain wasn't really coming from the knee, the worst of the pains. It might have come from radiculopathy, meaning the spine, a nerve from the spine happened to give a signal across the knee. And the patient also had knee arthritis on the X-ray, but it wasn't really the source of the pain. Does that make sense what I'm saying?
Yeah.
The other one is, it was done for the perfect reasons. The knee replacement is perfectly looking fine, but the patient, let's say for example, is overweight, very overweight and deconditioned. You can have a knee replacement, you can still have a ton of tendinopathies, meaning tendon pain around your knee replacement, because we don't make the tendons fresh, we only make the bony surfaces fresh, right? So the tendons might still say, not liking this situation, and give you pain. And another reason, of course, are the more sinister things that can happen, that you have an infection in the knee replacement, that can cause pain, and they can sometimes be a little hidden and obscure, not obvious. Another one is that the implant failed, maybe it got loose, it wore out. Shouldn't happen quickly after surgery, but there's a multitude of reasons. Typically, most frequently, it's that people are deconditioned. When they were deconditioned before surgery, they are still deconditioned after surgery, and they have pain from muscles and tendons around the knee.
Thank you.
And it goes to the reason too that I think the more miserable, the more frustrated somebody is before surgery, the happier they are after. I say the person that can hardly get around their house at night or during the day, unless they get an infection, they are almost all happy. The person that, I had a 57 or 8-year-old guy that wanted both his knees replaced. My only question is, when can I play soccer? He's a guaranteed unhappy patient. They are mechanical joints. They clunk around. You don't have an ACL in them. Do you do PS knees?
Yeah.
They don't have a posterior cruciate ligament. They have mechanical parts in there to accommodate for those. So they don't feel like what I remembered when I was 20. So expectations is a huge part of it. again, reasons to delay it as long as possible. And to know what you're getting. The more you can know about it before you get to it. Most surgeries we do, unless there's a bone sticking out of the skin, should be easy decisions. I don't want my knee replaced, but I can't stand this anymore. I've done everything I can. I've had enough. My shoulder. I'm frustrated. I'm miserable. I need something different. And if it's not a pretty easy decision, to me, nobody's going to operate on me for a minor annoyance, because I'll go through a major surgery, take on all the risks, go through a recovery process. But I say you'll see improvement for at least a year after a knee replacement. Your muscle strength, your balance, your coordination, your endurance, everything changes for a long time after the surgery. And if you weren't miserable beforehand, why are we in there?
So our time is up, I'm afraid. Thank you all for coming. We appreciate